Hello everybody, my name is Joseph. I'm a respiratory therapist. I've been working in respiratory therapy since about 2006, toward the end of 2000, actually the end of 2007. So I have about 13, maybe almost 14-ish years of experience when it comes to managing ventilators and trying to, really, be there when the train wreck is just really pulling the individual toward death. You know what I mean? We manage the physiologic challenges to keep air moving through the lungs. And also, we're trying at the same time not to do damage by, ramping pressures and energy needed up to, make sure this patient ventilates. So, COVID-19. Today is Houston's first day of shelter in place. It began about midnight this morning. But yeah, so the tide is like coming. You know what I mean? Like the tsunami. The low kind of bulgy portions of it are forming out in the ocean now, and it's making its way on into the cove and shores, man. So I was just gonna upload a quick video about like my tiny this is how we just prevent dying. This is how we maximize outcomes with very little clinical calculation and thought. So here's my basic principle based off of everything I've read on how COVID behaves, how it decides to attack, how it ends up creating conditions within the lung that are unfavorable for the treatment we try to do to it. And actually how I'll end the video on how I think perhaps maybe a form of hybrid ventilation might help in these cases. It might help reduce the positive pressure gradient with which we use to force air into the lungs. So this is basically what happens. COVID infects you, yada, yada, yada. It's really making things not work right when it comes to your lungs' normal response, which we have a lot of experience with, and that's what's throwing us off. Mucus is really thick. We have healthy cells that are being infected by the body's endogenous T cells, and so, the normal healthy pneumatocytes and whatnot are like, oh yeah, you're good, dude, you're like one of us, and then they get infected, and those T cells cause the healthy cells that aren't all interferon and going crazy out to die too, in close proximity to the ones that were infected and dying. So yeah, mucus is really thick. It's like some Chinese handcuffs. We push more pressure to try and fight the mucus, fight the obstruction, and then we end up doing more damage and causing those cells to commit suicide faster because we're creating more like a larger cytokine release, and the efforts to prevent them from dying, we are pulling the Chinese handcuffs away from each other. So here was my first, just kind of going down the same path in which we've done things for the past maybe 5 to 6 years, and that's with positive pressure. All right, only my positive pressure approach. My positive pressure approach, and this is like fully simplified, general method for anybody that does not have asthma-like tendencies while experiencing this pathology. So this is assuming like they're not clamped down, they're not sounding like an asthmatic. We're going to assume that aside from the COVID's inflammation, there's nothing else wrong with this patient yet. They're just dealing with the cascade and the cytokine storms. So with that being said, what my paradigm on this is to, one, we need to change, especially based on how the body tries to heal from this and form scars that become restrictive for the lungs. We need one premise here, and that is to maintain the lungs in a mainly open position for at least 75% of the time in breathing. And I made another video on this like 10 or 12 years ago. It's called Aprv, Airway Pressure Release Ventilation. So what we do is we have a set amount of pressure. Let's call it 20 to 25 centimeters of water pressure. Column of water, the amount of force gravity is pulling down on that column. We're going to use that to propel gas into somebody's chest, right? Now, in conventional breathing, you breathe in, you spend more time breathing out than you do breathing in. That's the way we normally do it. My reason for wanting to, there's two kind of perspectives in this. One, it's like physics. when you have a car and you want that car to go twice as fast, you need like quadruple the horsepower. Like the way the physics work is not just, it's not like linear. It's almost like not quadratic. Yeah, I guess, whatever. I'm really bad at math terms, but essentially, the more time, like to need to do something fast requires a lot more energy. But what if we had the luxury of increasing the time portion of the equation, thus heavily reducing the amount of work involved when it comes to continuing to ventilate, continuing to oxygenate? What if we could do that? What if the cytokine storm could, what if the inevitability of COVID cytokine storm, what if we didn't have to add to that? That's my Aprv perspective. Then I have like a, I guess the slightly hybrid perspective. And actually, no. First, I'm going to go into a little bit more my conventional Aprv management. So, like I said, we don't need high pressures yet. This patient is, they're not sick yet. Maybe our first X-ray shows the beginning of some, effusions happening. Some areas starting to show infiltrates. Maybe even, for really quickly progressing cases, some already localized ground glass areas that are, more distal, or even just like the primary site of infection. So essentially, what we're wanting to do is allow more time for oxygen to get across and more CO2 to build up, because what does CO2 do? CO2 is a bronchodilator. It bronchodilates. Who would have thought that the pulmonary architecture would design itself to respond to things that need to leave by making it easier for that thing to leave? It's pretty nice, actually. So, what I think is that by keeping a high level of CO2, we're actually reducing the amount of force it's going to take to get the air to move through the tubules of the lungs. And when the lungs start to swell, those tubules start to get a little smaller, and that fractal, that reversing fractal, passage way out from larger to large, from smaller to larger airways. We are drastically reducing the amount of work it's going to take to get air to move through all those. So that's the reason. That's another kind of side to the coin as to why I want to make sure the lungs are staying open most of the time. Mind you, people have an enormous misconception that you need to be paralyzed and sedated to be on Aprv. Motherfucker, you can intubate me right now, and if you didn't have me on Aprv or CPAP, I'm going to want to beat your fucking ass. You got me on AC? What the fuck's wrong with you? SIMB? Really? What? I can breathe now and now I can't breathe now? It's ridiculous. So, Aprv is an extremely comfortable mode. Why? It has a floating exhalation valve. That means that the machine does some pretty interesting calculations as to maintaining pressure on the inside by taking several hundred measurements a second as it's monitoring the amount of volume compared to how much it knows it's put in to get to each pressure. It's doing calculations and trying to keep air inside. As air's leaving, it's sort of like a brake. We call this PEEP. And so when you're breathing out, the machine lets air out, but it also kind of gives a little tap on the brakes. And of course, the harder we set this parameter, the harder that tap is. And of course, there's a brake locking type analogy to that too. It's where you can, there's several mechanisms. You can overdistend, you can collapse cardiogenically compromised patients if you use more pressure than is required to fill their atria. So, yeah, man, it's balancing a lot of factors, but I think Aprv is the number one way to go. Nextly is managing your time low. I think to do here would be to maximize the concentrations, or maybe even finding a nice spot to be on that curve parabolically to where we're in a medium between maximum CO2 removal per unit of pressure needed to ventilate, and then conversely, also making use of that washout, the bronchodilated properties of CO2. And then also, there was two concepts I wanted to go over. Because one of them would be way easier to introduce than the fucking second one. So the first one is to use a vest when it comes to suctioning and the normal management of a COVID patient that is experiencing, highly obstructive emergencies. We have to have a vest, and we need to know which frequencies and pressures will help the thicker consistencies of mucus move through those airways on the exhalation phase. when you properly plot your exhalation phase, you can do wonders for mucus. When you there's a trick, and I'm sure our educators know it a lot better than me, but you track your peak expiratory flow rate, and you try and you watch a few breaths, and you try to get the timing for the amount of time spent. The time spent exhaling is short. It should be under a second usually, and the only time that ever increases is when you have asthmatic tendencies. That's why this concept is less applicable to people with asthma and chronic restrictive or hyperreactive airway diseases. So, that being said, yeah, man, the vest would be an easy kind of segue, because the only other idea I had was to combine both negative pressure cuirass therapy with positive pressure to decrease the delta, the transpulmonary and transthoracic pressure gradients, so that we are detracting from the irritant, the physical irritant of that cytokine storm. So that's just my fire from the hip, man. That's just 10 to 13 years of trying to keep people alive on ventilators and witnessing train wreck after train wreck, of variety after variety of this or that, or kidneys, heart, or just lungs, a mix of all three usually. But yeah, I don't know if my wisdom is, this is just, what's today's date? Today is the 25th of March. So yeah, man, hopefully, somebody picks up on my reasoning here. I'm going to be trying to spread my rationale as far and wide to as many lung doctors as I can. Maybe it's useful. Maybe I'm full of shit. But that's what I got, man. That's what I think we can do to maximize outcomes. Where just really make sure those ratios that are actually the mortality drivers for this disease, let's operationally manage them risk-wise. It can be done. It's just whether or not the practitioners know what the fuck they're doing. And I'll be honest with you, I'm sorry, but I hate my career field. I don't like the lack of scientific thought, the complete underling relationship we have with physicians and nurses, that we're just these, I have my own professional gripes, but yeah, I guess this is our time to shine or whatever, and to make sure that outcomes really actually improve, and to really use our expertise. Because I guarantee you, man, there may be 155,000 of us, but very few of us think this way. Very, very few of us want to really get it down to the pathophysiological, analytical level as to what's actually occurring and making a difference, in these cases. So, yeah, man. I hope me and the rest of my field get it together, and hopefully we can start, actually making a difference.